Well, welcome everyone. It's my pleasure today to welcome you to the first pulmonary grand rounds of the new year. And it is really my great pleasure to introduce Dr. Lauren Ferrante. Dr. Ferrante is a newly promoted associate professor of medicine in the section of pulmonary critical care and sleep medicine here at the Yale School of Medicine. She's also the director of the operations core of the Claude D. Pepper Older Americans Independent Center. And as you all know, she attends in the medical ICU here at Yale New Haven. She's lucky to have a amazing research program, which has been funded continuously by the NIH. She's been the recipient of a Beeson Career Development Award, as well as a GEMSTAR Award, and recently funding through her first R01. Her research is centered on the interface of critical care medicine and geriatrics with the overarching goal of understanding and improving the functional outcomes of critically ill older adults. Her work has been recognized most recently with the Joe Ray Wright Award for Outstanding Science in 2023 from the American Thoracic Society, where she also serves as co-chair of the Aging and Critical Care Interest Group and the chair of the Critical Care Program Committee for the ATS 2024 International Conference. And it has been my pleasure to know Lauren since she joined us here as a pulmonary critical care fellow. And I am amazed and proud to see how wonderful she has done with her research and her career and her mentoring. And it's been truly a pleasure to be able to work with her. So I'm gonna welcome her to the podium so she can share with us her talk from the ABCs to the 4 M's, bridging critical care and geriatrics to improve outcomes among critically ill older adults.
Thank you, Margaret, so much for that kind introduction. And thank you to all of you who are joining us in this 100-degree room in Fitkin. I will not be upset if anyone needs a water break or to shed some layers because it is hot in here. But I'm really excited to be kicking off Grand Rounds in 2024. So let's go ahead and get started. I have my required disclosure side, and I'll just say that I have no conflicts of interest to disclose. There's the, oh, am I supposed to read the number? So the number for today's CME is 40593 if you want to get CME credit. As Margaret mentioned, I'm supported by the Pepper Center at Yale. I'm also supported by the Lantern R01, and then the work that I'll be describing today was also supported by these other grants, so I just have to acknowledge them. So the objectives of today's talk are threefold. So first, to anchor us, I want to just define disability and describe its importance as a health outcome among older adults, kind of to set the stage for why my program focuses on this. It's its central focus. Second, to discuss geriatric syndromes and social and socioeconomic factors that increase the risk of poor functional outcomes among older ICU survivors. And then third, to consider how key concepts underlying geriatric models of care may be applied in the ICU to improve short and long-term outcomes. And so I think it's always useful to start with a case presentation. And so this was a real patient in our ICU. He's a 79-year-old man who was admitted to our MICU with pneumonia. And before he was admitted to the ICU, he was only dependent in grocery shopping and driving due to some mild cognitive impairment, but was otherwise independent in ADLs and other functional activities. He was on the vent for 5 days and his course was complicated by delirium. And he was initially discharged home with services due to some in-hospital functional and cognitive decline, which is pretty common, but he never achieves functional recovery. And because of persistently worsened disability, he's admitted to a nursing home 1 month later, which is a loss of independence. So just to define disability, when I refer to disability, I'm referring to dependence in activities essential to independent living. So these fall into 3 categories. The first is basic ADLs. So those are activities like bathing, dressing, walking across a room, and transferring from a chair. Instrumental activities of daily living. So these are higher order activities like shopping or housework, and then mobility activity. So something like walking a quarter mile or climbing a flight of stairs. I've listed certain activities on this slide because I'll refer to them later on a scale of 0 to 13, which is a continuous variable we use in some of our work. And why, again, I mentioned that at the beginning, I was going to talk about why this is the central focus of our program. Well, the reason for this is that functional outcomes and maintaining functional independence is the most valued health outcome priority for older adults. So this first paper here was, this is work done by Terry Freed back in 2011, published in what was then Archives of Internal Medicine, where they surveyed a number of older adults and learned that more than 3/4 of them listed maintaining independence as their most valued health outcome priority, where only 11% listed staying alive. There was a follow-up paper in the New England Journal that confirmed this work. And when you conduct the same or a similar study in the general ICU population as Katie Aremia did, she's at Penn recently in the last 2 years, it's exactly the same numbers. So 3/4 of people value maintaining functional independence as their #1 health outcome priority. And again, only a much smaller percentage would prioritize staying alive first. And so when we go back to our older ICU patient, and we think about the 3 domains of the post-intensive care syndrome, which for those of you who may not have heard of this is after you've survived the ICU stay, having impairment in either physical function, cognitive function, and or mental health. We can see that our patient suffered from both post-ICU syndrome impairments in physical function and cognitive function. And for him, that definitely led to a decreased quality of life, as was shown here in the stakeholder report where they established these definitions. But for our older ICU survivor, this led to a loss of independence, which, as I just told you, was probably his most important health outcome priority. And so this is why in my research program, I have centered it around understanding and improving the functional outcomes of critically ill older adults, because their primary focus is maintaining functional independence. And so I wanted that to be the primary focus of my research program. Although, of course, we obviously look at other outcomes as well in our study. And so we've tackled this in a number of different ways. So first, I'll just say we always try to think across the continuum of critical illness. We might see people only in the ICU, but actually the whole story of critical illness and what's impacting their outcomes begins before the ICU and of course continues long after we say goodbye to them in the MICU. And so we have tackled this through epidemiologic work, predicting this includes some prediction modeling. I've listed out some studies here because I'll be referring to them during the course of this talk. I'm going to talk to you briefly about a post-ICU recovery study and then an ICU interventional study called ACE-ICU that actually has included a few people in this section. Okay, so let's move on to the second part of the talk. So I'm going to discuss some of the factors that increase the risk of poor functional outcomes among older ICU survivors. And since I can't, this is a long list and we're not going to have time to cover everything, I'm focusing first on a geriatric syndrome and then second on social factors. But before I move to the specific geriatric syndrome and really do a deep dive, I wanted to share with you this study that I collaborated with some colleagues from UCSF on, where we looked at data from the health and retirement study between 1998 and 2015 to try to ascertain how rates of frailty, disability, multimorbidity, and dementia have changed or not among older adults admitted to the ICU over that time frame. And as you can see here, from 1998 to 2015, the rates of pre-existing disability, frailty, and multimorbidity all increased among older patients admitted to the ICU. I circled the rates here on the right, but you can see that many of them are quite high. And I put this little Uncle Sam here because I wanted to emphasize that this affects you. This affects all of us taking care of older adults in the ICU. So when you have an older adult patient in the ICU, and I will just tell you that right off the bat, older adults, meaning those 65 and older, compose about half of our ICU population at any given time. About 72% of them will be multimorbid, meaning they have 2 or more chronic conditions. 45%, so nearly half, will be frail, meaning they have increased vulnerability to adverse outcomes, and I'll go over specific definitions for that in a moment. and about a quarter will be disabled in ADLs. Not any functional activity, but ADLs, meaning their ability to bathe, dress, transfer, or toilet, really basic functional activities. And so this is really important for us to know about as ICU providers and to be aware of the fact that the rates of these pre-existing vulnerability factors are increasing over time. And so a good way to think about this is if somebody comes in with one of these pre-ICU risk factors, and then they withstand the hit of the ICU and manage to survive, they have a much greater chance of in-hospital and post-ICU functional decline. So a much greater chance of experiencing one of these impairments in the post-ICU syndrome. And so let's talk about frailty, because this has been a hot topic now for several years, but I'm still not so sure that a lot of people fully understand what it is. There are two ways that we can really think about frailty. The one on the left is the freed frailty phenotype. This includes 5 components, which if you think about it, they make a lot of sense in thinking about why someone might have increased vulnerability to adverse outcomes. So the person has slow gait. They have unintentional weight loss or a BMI below 18. They have low energy, they're weak, they have a weak grip strength. And actually, although it says falls there, the 5th criterion is actually exhaustion. So when you ask them about exhaustion, they answer affirmatively in a certain question. And having 3 or more of those 5 components indicates that somebody is frail. There's also an accumulating deficits model, and that's actually what the clinical frailty scale is derived from. The clinical frailty scale, it kind of incorporates multimorbidity, disability, and then some of these other components, and it gives you a range all the way through from completely independent through terminal illness and rates where the person is on a frailty scale. But without getting into the nuances of the scales themselves, the bottom line that you all need to be aware of is that frailty, whether measured through the freed frailty phenotype or the clinical frailty scale, is associated with poor functional outcomes after critical illness. So specifically associated with increased disability, which is what we started talking about. And this was the chest paper. I just showed you the title on the prior page, but just to dive into it a little bit more. So just like in that HRS study that I showed you a little while ago, where we collaborated with investigators at UCSF, the rate of frailty in our study was about 45%. Again, nearly half of the older adults who were admitted to the ICU among the 266 in this study. The mean age in this study, again, they are older adults. The mean age was about 83. And then pre-frail, meaning that they had 1 or 2 of those criteria, pre-frailty was present in the other 43%. And you can see that only about 12% were robust. And in our multivariable model, the adjusted rate ratio for frailty, and a good way to think about it is to look at the area under the curve. So if you look at the frail group, that's the green group here, their burden of disability, so meaning the area under the green curve, was about 41% greater than the burden of disability experienced by the non-frail group. So that would be the area under the curve of the white group. So I'm a visual person. It's just a helpful way to interpret that, the figure. And then the corresponding value for the pre-frail group was a 28% greater burden of disability. We also looked at mortality as a secondary outcome in this study. This has also been done by Sean Bagshaw's group using the clinical frailty scale. And you can see that these 2 figures really align nicely and demonstrate that frailty is a powerful risk factor, not just for inpatient mortality, but actually for mortality after critical illness. So our study went out to 6 months, and his went out even farther. And you can see, at least in our study, the frail group really drops off. And then in his study, with the clinical frailty scale, also the frail group has much greater mortality over time. And you might be thinking, well, Lauren, you're talking so much about older adults. That's half of our ICU population. What about the other half? Well, frailty is actually very relevant to the other half as well. So there's already been work showing that frailty can exist in younger adults. And in this recent study that came out of Australia in chest in 2021, I think you guys are probably familiar with the ANZICS group, the Australia and New Zealand Intensive Care Society. They have a very large research network, and they actually had research personnel in many, many ICUs, 175 across Australia and New Zealand. and they had them ascertaining clinical frailty scale status on everyone admitted to those ICUs between 2018 and 2020. And even among the entire ICU population, inclusive of younger adults, almost 1 in 5 had frailty prior to ICU admission. So this affects not just older adults, but can affect anybody that we're seeing in our ICU. And this was associated with worse outcomes. Now, when I speak, especially overseas in Europe, people ask me if frailty can be used for ICU triage. We tend to think about things a little bit differently here in the US, but that's still a pretty big focus there. And because of those questions, and kind of to stave them off and lead to a point I'm going to make a little later, I did want to share with you that the issues with frailty right now actually relate primarily to measurement and inter-rater reliability. So even the clinical frailty scale, because it's a subjective scale, and even if it's being performed by providers in the hospital, inter-rater reliability is still not the greatest. So if you look here at this study, here they had Pew and colleagues, this was done overseas, they basically looked at different combinations. So doctor, nurse, nurse, physiotherapist, and performed CAPAs in terms of frailty assessments among these groups. And although the CAPA of nurse physiotherapist was the best and the others were okay, there were still score differences in about 47% of cases. And there was another study where they brought in geriatrician consultants and did the same thing with geriatrics residents, geriatrics attendings compared to critical care attendings. And these CAPAs, again, were actually between geriatrics and critical care were actually quite poor, but among geriatric residents and geriatric attendings were much better. Nevertheless, the reason that I mention this to you is because when we think about the appropriate use of frailty in ICU practice, my recommendation would be that we do not use this in ICU triage, not because of the lack of an association with outcomes. We know that frailty is incredibly strongly associated with poor functional outcomes and mortality, as I showed you already, but because implementation and measurement of frailty are far from perfect. There are issues with inter-rater reliability. And so if you're thinking about something like ICU triage in the first place, it really wouldn't be appropriate to use it there. But frailty can still be very useful. The two ways I would recommend that we use it would be to inform shared decision-making with patients and families. So even if, the exact score isn't perfect, the difference between like a 4 and a 5 is probably not so important where you're using it to have shared decision-making conversations with families, right? And then also to target patients for rehab and restorative interventions. There are actually studies like the LIFE study that have had specific sub-studies where they focus on frailty and have shown that frail older adults still benefit greatly from rehab, both including after discharge. And you'll note that here I mentioned that pre-ICU functional status and functional trajectory may be more helpful. And why am I saying that? Well, that's because actually the measurement issue is really not quite present here. It's much more straightforward to measure functional status. And I've provided an example here on the call out, which kind of drives home this point. So when you're ascertaining whether or not someone's disabled in a functional activity, the way we define disability is that they need help from another person to complete the task. And so you can see how it's quite easy to say to someone, do you need help from another person to use the toilet? Most people can answer that pretty reliably, as can their proxy or their surrogate. And so it's actually much more straightforward to ask these questions about functional status. And for now, over 20 years, it's been well established that reports of pre-admission functional status by hospitalized older adults have both face and predictive validity. And just to orient, I'm going to touch very briefly on a study that we did early, but the take-home point is important. So just for those of you who have not heard of this study before, we used data from the Precipitating Events Project at Yale to demonstrate just how important functional status and trajectory are in outcomes among older ICU patients. And so this is a longitudinal cohort study of 754 older adults who were enrolled while living in the community and were initially non-disabled. They've been followed every month through the present day with monthly assessments of disability in the 13 functional activities that I showed you early in the talk, and with comprehensive in-home assessments every 18 months. And so as an epidemiologist, it's really quite lovely to have a cohort like this where one can go in and then pull out the ICU admissions, and you have prospectively measured frailty, function, including for the months leading up to an ICU admission. And so we conducted a study where we first evaluated the functional trajectories among 291 older adults admitted to the ICU. And we looked monthly at their measures of function in the 12 months leading up to the ICU. Then we looked with fresh eyes at the 221 who survived the ICU stay, and again used latent class analysis to categorize them into trajectories. We then evaluated the probability of transitioning from a pre-ICU functional trajectory to a post-ICU functional trajectory. Here you can see that if about a third of the patients had really no disability leading up to their ICU stay, and basically experienced what might be considered a catastrophic ICU admission. But their pre-ICU functional status and their functional trajectory was actually really helped them so much in terms of their post-ICU functional trajectory. They only had a 13% probability of transitioning to a trajectory of severe disability, and a 20% probability of transitioning to a trajectory of mild to moderate disability. Whereas the group of about a quarter of older adults who were coming into the ICU severely disabled, first of all, you can see that none of them improved. 2/3 remained severely disabled after the critical illness, and a third experienced death within 30 days. And so it's actually very well established in the geriatrics literature how important functional status and disability are. But here we demonstrate just how important it is in thinking about outcomes for our older ICU patients. We also showed in this study that pre-ICU functional trajectory was as important as the need for mechanical ventilation. And so my recommendation as it relates to functional status is to ask older adults or their proxies about baseline functional status and trajectory leading up to the ICU admission. And I do want to highlight that that report by Ken Kavinsky in 2000 also demonstrated that the proxy reports were reliable and valid among hospitalized older adults. So you can actually ask the patient or their proxy. Okay, so what about social factors? I mentioned that I wanted to talk about this today. So I think that we all are intimately familiar now with social isolation after living through the pandemic. In the geriatrics literature and among older adults, there was actually a lot more being written about social isolation even before the pandemic. And in the fall of 2019, believe it or not, I decided that I really wanted to dive into this and whether this was a risk factor for poor functional outcomes among older adults in the ICU. We are in the middle of this analysis when the pandemic struck, and so it became actually much more relevant. And to conduct this work, we actually used data from the National Health and Aging Trends Study. This is Jason Falvey, who is a mentee of mine who did his postdoctoral fellowship here at Yale. So this was Jason's postdoctoral fellowship project. So in this study, the National Health and Aging Trends Study, I'll just say, is an amazing resource. Bless you. It's a nationally representative sample of Medicare beneficiaries age 65 and older. And so basically they sampled older adults who were on Medicare, and then through survey weights, strata, and clusters, you can get nationally representative estimates for your analyses. This is a contemporary cohort. So initially enrolled a cohort in 2011, and then it's replenished every 4 years. And the really nice thing about it is that it's focused on function, disability, and other geriatric syndromes, all of these things that are really important to older adults, whereas many cohorts not focused on older adults or function may not include some of these factors that we need. It also includes a detailed last month of life interview. And so one of the, some of the questions pertain to social connectedness. And so just as a definition, social isolation is the objective lack of social connections to those around us. This is different from loneliness, which is a subjective feeling of wanting to have more social connection. Okay, so those are two different things. And for those of you interested in this area, there's a fantastic report by the National Academy of Medicine from just a couple of years ago on social isolation and loneliness. But in NHATS, we have a 6-component variable to to define social isolation, where higher values indicate more social isolation. And as you can see here, the indicators all ask about basically how objectively someone is connected to family, friends, and the community. And so the primary outcome for this study was disability in 7 functional activities, actually ADLs and mobility activity. And our secondary outcome was 1-year mortality. You could see here that we adjusted for a number of covariates, including some of those that I've already mentioned during this talk as being relevant to post-ICU functional outcomes. And so here you can see, this is one of our figures. You can see that greater social isolation is associated with an increased burden of disability in the year after the ICU hospitalization, such that the most severely socially isolated older ICU survivors experienced a 50% greater disability burden in the year after critical illness. And then in our secondary outcome, where we looked at a multivariable model for time to death, greater social isolation was associated with an increased death in the year after the ICU hospitalization, such that the most severely socially isolated, again, those with a score of 6 out of 6, had a 119% greater hazard of death. And so at the time, this was the first time that social isolation really had been described as being important, but I think for all of us who see patients, it's really easy to see how this may be true. So the person's already coming in isolated, and now they've been through this catastrophic illness, and then to go home and try to recover, there's there's the whole support network piece in terms of social support, but there are also practical elements related to recovery. So getting to appointments, getting to rehab. I mean, you could think through all the reasons for why this may be true. So this paper was really set out to establish the problem, and now we have some follow-up work, actually a grant under review at NIH to do some more work in this area. And I just want to give a shout out and highlight another one of my mentees, Snigdha Jain, who I know is on Zoom. Hi, Snigdha. But she'll be giving research conference later this spring. But Snigdha also was my mentee during her postdoctoral fellowship. And Snigdha and actually Jason as well are really interested in socioeconomic disadvantage. And so Snigdha has focused on this at the individual patient level. And Jason, who's a physical therapist PhD, at the neighborhood level. And so I'll just very briefly touch on some of the findings that we've worked on. So in this study, I already mentioned to you the 3 domains of the post-ICU syndrome, but we were really interested in exploring whether socioeconomic disadvantage is associated with decline in physical function, cognitive function, and mental health after critical illness. And so we used data from the National Health and Aging Trend Study for this work, and this was published in Annals of Internal Medicine. And what we found was that so first of all, we define socioeconomic disadvantage as dual eligibility for Medicaid and Medicare. And we found that dual eligibility was associated with a 28% increase in the burden of disability after critical illness, as well as a nearly 10-fold increase in the odds of post-ICU cognitive impairment. So again, this paper also is kind of establishing the problem. And now Snigdha has follow-up work that's really diving into why this might be, starting with looking at equitable delivery of rehab during and after ICU admission, which she'll talk to you about at her research conference later this spring. Jason has tackled this at the neighborhood community level. So he thinks a lot about, we've used in his work, the Area Deprivation Index, which basically uses something called the Neighborhood Atlas, which you can find online for free. Amy Kind out of Wisconsin published a New England Journal paper about this and how strongly associated it is with outcomes. Basically, it's even better than census block data in really pinning down how somebody's neighborhood maybe actually look like this, where it's easy to see how this could actually affect someone's ability to function and could affect their outcomes. And so we thought that this would be impactful for recovery after critical illness. And what Jason showed in this paper, which we published in Critical Care Medicine, was that living in a disadvantaged neighborhood was associated with an increase in disability burden. And so he successfully applied for a Beeson Award, which is a career development award through the National Institute on Aging, where he's doing some community mobility work now to really dive into this problem and to come up with interventions. And so the reason I wanted to talk about those social factors was not just to highlight the work of my mentees, which I always want to do, but also to encourage all of us to really think across the continuum of critical illness and recovery. we only see patients during this tiny sliver of time and that first red bar that says ICU. But then they're going to the floor, then they go home, and then there's actually this quite long period of time where they're trying to achieve functional recovery. We showed in one of our early papers in the Blue Journal that the median time to functional recovery is 3 months for older adults and often takes up to 6 months. After 6 months, there tends to be a plateau, although recovery could continue for some people. But here during this time, we do have opportunities to intervene. So we may be seeing these patients in outpatient clinics, and this is a good time to put in a plug for our new post-ICU clinic that just opened at Yale. Patients might be getting readmitted, but maybe they're not just getting readmitted because of a diagnosis of some infection. Maybe they're getting readmitted because there were also things happening at home that were kind of setting them up to be readmitted. And then of course for research. So from the research standpoint, which is what I just want to touch on very briefly now, I guess this is not just clinical, this is not just research, but also clinical. These are all the things that could basically go wrong once someone is home. Sam Brown and others published this in the White Journal in 2019, and it really kind of lays out all of the potential problems. And I would say the list is probably even longer. And so we have some direct experience with this, and I'll explain this in a second, because this is actually what led to my current R01. So in 2020, I was part of an international consensus conference on prediction models to predict the post-ICU syndrome, because those of us in the post-ICU outcomes research world were really struggling with the whole after the ICU discharge period, which I just mentioned to you. There have been a number of interventional studies, and all of them have been negative in improving outcomes. And so the thought was maybe we need prediction models to accurately identify those who are at greater risk of not recovering, and then they could be targeted for interventions. Now, incidentally, I had already submitted my Beeson Award, my Career Development Award, to tackle this very problem in older adults and to develop and validate a risk prediction model for the physical function domain among older adults. And so we went and did this work. We developed and validated a risk prediction model for persistent functional impairment among older ICU survivors. And in the interest of time, I'm not going to dive too deeply into this study, except to say that these are the factors in the final predict model. It performed pretty well. And then we do have this integrated predictiveness curve in the paper. If any of you are interested in plugging in the number we put in the equation so that clinicians will know how to use the model to help, advise their patients about their risk of not recovering after the ICU stay. But in the interest of time, I'm actually going to get on to what's the even more interesting part of this work. So we took the prediction model and we implemented it in the hospital because we wanted to, I thought this was going to be my first R01. We were going to implement it, get some data, refine the model, build it into the hospital, into Epic, deliver it, and this would be the first R01. What happened was we started talking to patients every month because our primary outcome was disability in the months after discharge. And all we kept hearing from patients was that they had unmet needs in various domains. I put one sample quote here from one of our PREDICT pilot study participants. And when we looked to the point that this happened pretty early on, I ended up adding in a question so that we could start capturing all of these data in the pilot study. When I looked at the literature, there was one other study that had looked at unmet needs called APEX, and it was in younger ICU survivors and really focused on medical needs. When we looked at the pilot study data from our older adults, they were all plugged in with their doctors. Nobody had a medication issue. There was one person who needed their AFib medication adjusted, and it had already been handled by their doctor. But they had unmet needs in a number of other domains, including in the home environment, like this person here, who is at risk of falling and couldn't shower independently because of this problem of not having the support that she needed. And so basically, we followed the science or listened to the patient, and rather than writing the prediction modeling R01 that I thought I was going to be writing, ended up putting in an R01 on this topic. And that led to the Lantern study, which stands for evaluating the unmet needs of older ICU survivors to improve functional recovery after critical illness. And so I'm happy to say that we actually started enrolling last week. We opened enrollment a week ago, starting today. And you'll be seeing our research team around the MICU at York Street and SRC and Bridgeport, for those of you who are on the line for Bridgeport Hospital. So we'll be enrolling, it's a 5-year study, so we'll be enrolling for at least the next 3 years. Okay, so now I'm going to pivot to the last third of the talk. I want to talk to you about how key concepts underlying geriatric models of care may be applied in the ICU to improve short and long-term outcomes. And I'll be touching on some pilot work in this study that's going to lead to the next grant that I'm pretty excited about. The only thing I'll say is this paper is actually under review right now at the White Journal and in revision, so please just don't tweet. I put the little X'd off bird in the corner. So I think all of you are familiar with the ABCDEF bundle. This is a evidence-based components for at least the ABCDE elements that are known to improve outcomes. This is kind of considered best practice or standard of care in ICUs across the country. And just to highlight one element of it, we know that early mobility, for example, can prevent in-hospital functional decline, improve a number of outcomes. The idea is that we're addressing this acute skeletal muscle wasting that we see in critical illness. And in the hospital, this can happen with older adults too, too much bed rest, functional decline, and so we mobilize patients. But what are geriatric models of care? How can they build on existing ICU care bundles to improve outcomes? And how are they different from what we're already doing? So geriatric bundles of care are similar in their idea in terms of each component being evidence-based. And the idea is that you put all of them together with a goal for that patient to provide best possible care. But the ACE model and the 4Ms model, which I'll show you in a moment, are geriatric models of care that kind of take this to the next level for older adults, in that the focus is actually to reduce in-hospital functional decline for older adults. These have been around for a long time. There are two, they actually all started back in 1996, believe it or not, in the New England Journal, when there were two randomized controlled trials showing greater functional independence among patients aged 70 and older at hospital discharge compared to usual care. For the ACE model, there are 5 key elements. These elements all work together to improve functional outcomes for older adults in the hospital. And you can see here that one of these elements is early mobility. That's why I just highlighted that from the ABCDEF bundle. There's also another geriatric models of care called the 4Ms. This is what's being implemented throughout the country in age-friendly health systems, where we're trying to get hospital systems to think about what matters most for older adults: medications, mentation, and mobility. And a good example of how these geriatric models of care differ from ABCDF would be, I'll highlight one component, which is hearing impairment. So hearing impairment is really common. It affects 50% of patients over the age of 75, a third of people 65 and older. It's often untreated due to cost, and it's associated with a number of adverse outcomes, including delirium and cognitive decline, as well as a lack of functional recovery after the ICU, which we showed in a paper in the Blue Journal from 2016. After doing this study, this has always been in the back of my mind that, of all the studies, all the factors we looked at in this study, which was like 27 factors, it was actually severe hearing and vision impairment that came out as being most strongly associated with the lack of functional recovery. And I think I love research, and that is, you can work on something that really bothers you. And so this problem has always bothered me. We know that geriatric models of care improve outcomes for hospitalized older adults. If you were to read the systematic review that I put at the bottom here, you would see that there are fewer falls, less delirium in the hospital, less functional decline, really a very large body of literature supporting the implementation of geriatric models of care in the hospital. Yet for some reason, there has been this brick wall when it comes time to move them into the ICU. It's just like never happened, and I just don't understand why. And so what's really fun about research is, you can now go ahead and get some pilot funding to work on something that bothers you. And so this has always bothered me. And so I proposed the ACE ICU pilot study. ACE being a reference to the acute care for elders model. And so what I did was I looked at the acute care for elders model, or the ACE model, and I mapped that onto what we were already doing in the ICU, especially with the ABCDEF bundle, and I identified 3 components that were missing from usual care in the ICU. So the first one was this kind of the prepared environment piece. So the prepared environment and the ACE ICU are physical changes to the ICU environment or the environment around the patient to improve outcomes. So here you can see that this is physically putting on a hearing aid or a hearing amplifier to the patient. I also noticed that we really, although we're very fortunate to have ICU pharmacy with us, there's a big deprescribing movement in terms of removing harmful medications for older adults. And we really didn't have a focus on doing this in ABCDEF. And then also this focus on transitions of care and early rehab. We have a very robust STEPS ICU program, but it really focuses on mobility and a lot on physical therapy. And it seemed to me that we could have much more of a focus on occupational therapy because OT will tend to focus more on function, both physical like ADLs as well as cognitive function. And so this led to, as I said, the ACE ICU pilot study, which is an interventional study that includes 3 components. So assessment and treatment of hearing impairment, deprescribing potentially inappropriate medications started in the ICU upon ICU to floor transfer, and default occupational therapy evaluation and treatment. You can see here that Margaret and Luke are both part of this study. And the study has 2 primary objectives. So one of the first objective that I've listed here is actually an implementation science objective. And that was because reviewers came back to us and said, this is implementation science. And it was actually a very helpful comment because I realized that we can, in working with Luke, that we could actually think about hybrid designs going forward after this study, like combined a hybrid implementation effectiveness trial for the next phase of this. And then our other primary objective was to evaluate the effect of the intervention on incident delirium. And initially we were looking at hospital length of stay, but we will look at that, but our primary was incident delirium. You'll note that I wrote that we used the chart del there. That's because we learned during the pandemic that the CAM ICU is not reliable, which I'm happy to talk to anyone about after. And this was a pre-post study design in our York Street MICU. The design is that patients were enrolled within 72 hours of ICU admission. They had to be 65 or older. And upon enrollment, 3 things happened. So first, ICU pharmacy was notified through mobile heartbeat that the patient was enrolled. Second, the patient was given a portable hearing amplifier, which is called the Super Ear, which I've included a picture of there. For those of you who remember what a Walkman looks like, it looks exactly the same. You put in little plugs and put the headphones on, and then the person can hear. And of course, the research nurse would just educate the patient and proxy, if applicable, and the nurse on how to use it. And then upon enrollment, an occupational therapy order went in, which for all of you who work in the ICU, you know that that's pretty easy to find. You just type in OT and place the order. The intervention is that, so once those 3 things happened, and you'll note that none of those 3 things require the physician to intervene, that was intentional. ICU pharmacy would review charts. Initially, we focused on them reviewing at the time of transfer out of the ICU, but they were missing some people. So we changed the protocol where they would just review the charts regularly and make deprescribing recommendations or other medication recommendations to the team. The hearing amplifier, the participant was encouraged to use it throughout the hospitalization. And then OT occurred. Once the order went in, we didn't do anything else. They just used their standard protocols in terms of treatment and whether or not to continue. And then our primary outcome was incident delirium. So at enrollment, we then looked forward to see if anyone developed delirium and compared the rates. And we looked at this daily through hospital discharge. And so briefly, these are our ACE ICU participant characteristics. We had 50 participants in the intervention group and 22 in the control group. You can see again, these are older adults. And that, let's see, about in any pre-ICU disability occurred in over 70%. Many of them were frail. And so this is the table that really highlights delivery of the 3 ACE ICU intervention components. So I'll just walk you through this because it's pretty important. So for occupational therapy in the intervention group, 98% of the group had it ordered compared to 59% in the control group. And we are reporting here both ordered and received. So you can see there are pretty significant differences here in delivery of OT between the 2 groups. In the next 2 rows, I'm highlighting to you that mobility with physical therapy was not any different. Again, I had nothing to do with, this is just the study happening, but I just want to highlight that the differences I'm about to show you have nothing to do with mobility, because both groups, and kudos to all of you for implementing ACE-ICU, 90% of both groups ended up having physical therapy ordered in the ICU, and the maximum level of mobility achieved in the hospital was the same between the intervention and control groups. For ICU pharmacy, they ended up getting actually to pretty high numbers of both groups' charts, including the control group charts. But of the patients who required a medication intervention, more participants in the intervention group ended up having medications discontinued. And then for the hearing intervention, of course, everyone in the intervention group received it. And just this bottom row is our feasibility outcomes, so you can see that we achieved it. I want to highlight that for occupational therapy, this default ordering of OT within the first 72 hours resulted in pretty substantial differences in the amount of OT treatment received throughout the hospitalization. So if you look here, the red circles are the control arm and the blue are the intervention arm. And the size of the circle is telling you the N, so the number of participants that achieved that much OT. And you can see here that the control arm is centered pretty much around 0 or very little. Whereas once that order went in, just that default going in resulted in all these intervention patients getting OT for the rest of the hospital stay. And the hearing intervention also had pretty significant effect on people. I actually I like to highlight the qualitative comments we received, because we did ask participants for feedback. This is going to be pretty important going forward. And I'll just give you a moment to read this comment from this participant. So when I got this comment, I mean, it was just so incredible to me. And this really highlighted something that our audiologist collaborator had shared with us, which is that a lot of older adults don't know they're hearing impaired. And that it's kind of hard to imagine, but this comment really just drove that home. And so that was why in our design, all 3 of the intervention components were delivered as a default, including the hearing amplifier. Because if we had asked people whether they were hearing impaired before giving it, we could be missing people. So it was much better to just deliver it and then have somebody not need it. Okay, and so drum roll. So the primary outcome, which was incident delirium, and I deleted hospital length of stay because I wanted to highlight this, so I apologize for the title, but we actually did see a significant reduction in delirium. I do want to remind all of you that this was a pilot study, so typically I wouldn't even report a statistical comparison, but we wanted to run it because we thought this was important. And of course, this is going to be important for the next phase of this work because we'll need to use these numbers for power calculations. But basically, the control group rate of incident delirium was what we would expect to see, about 35% of participants. And we were really surprised and happy to see that the intervention group had a much lower rate of incident delirium, only 12.2%. And so this work, as I mentioned already, is actually under review at the White Journal. So please don't tweet it, but it just got a favorable review. So hopefully you'll be seeing it in a couple of months. So next steps, we intend to, I think it's too much to go from this to a multi-center trial. So we're planning probably a Yale Health System-wide multi-site stepped wedge trial. Michael Harhay was here a couple of months ago. He's probably going to be our biostatistical collaborator. And we worked out that this will likely be a stepped wedge trial and probably a type 1 hybrid effectiveness intervention study. And we're interested in seeing whether this intervention reduces incident delirium, days of delirium, improves functional outcomes, decreases polypharmacy, among other things. Okay, so take-home points. So first, I do want to remind you that functional independence matters most to older adults as a health outcome. And so we all need to be thinking about function and recovery across the continuum of ICU care and recovery, including when we see these patients afterwards. Risk factors for poor long-term functional outcomes include geriatric syndrome, social factors, and a number of the factors I listed on that earlier slide. So just remember to ask about these risk factors, and if you're pressed for time, just ask at least about functional status and trajectory. The social factors I want to mention, CMS is actually adding in mandatory screening for a lot of different social determinants of health and health-related social needs, and social isolation is actually going to be screened for starting in 2025. And it's already appearing in EPIC in certain places, so you'll have those data too. And then lastly, a strong evidence base underlies geriatric models of care, and hopefully building these model components onto ICU best practices will help us improve outcomes among older ICU patients. And so with that, I want to say thank you for your time and attention. I would like to acknowledge everyone on this slide without whom this work could not be completed. And actually there are many more people because I couldn't talk about all of these studies. So I just want to say thank you to everyone. I want to extend special thanks to Tom Gill and Margaret Pisani, who have mentored me through fellowship and throughout my career. And I'll take any questions. Thanks to all of you.
All right, so this presentation is now open for questions.
Wow, Lauren, that's so amazing. Congratulations. You know, I'm wondering if you step back, you know, there's a lot that's been said about the current state of critical care, and even if we're tackling the acute reason for the patients being in the hospital, we end up somehow making them worse in lots of unpredictable ways. And, you know, like Melissa's talked about sleep deprivation, and, you know, I think a lot of the chaos during COVID, I think, led to some sketchy practices like over sedation. And so I'm wondering, to what extent do you think these poor outcomes that patients are experiencing is part of a more global problem that we have with ICU function right now? I mean, we're just overwhelmed, like rounding till 2 o'clock in the afternoon we hear about, and you know, just so much to get through in these incredibly complicated patients. You can imagine how you don't even have time to think about things like deep prescribing or, you know, getting the OT order in. I mean, it seems to me you're almost just like this, I just feel like you're just getting started and that there must be a lot more that needs to be tackled.
That's a great question, Mark. And I think that really highlights one thing I said when I explained the design of the intervention, which is that we just can't be responsible for it, like the physicians. It needs to happen. So first, I'll say two things. First of all, this is the point of care bundles, right? Like if we know there are evidence-based practices and then we have something like the checklist or care bundles where this is becoming systematic and kind of part of rounding, then that's a good way to check and make sure these things are happening. And I think all of us run the checklist at the end of rounds so that we don't miss those things. So the bundles are important. And that's actually, I didn't mention, but the geriatrics bundle, the idea is that hopefully it will become G, like the actually part of the bundle. And then the second piece of it, I think, is beyond those things, or perhaps when we're developing new interventions that may be later added to those things later, it's really important that we think about how to just have them become part of usual care or the care that's already happening because of what you described, this limited bandwidth and limited like mental capacity to think about anything else. And so when we were designing this, we really wanted it to just make sure that those three components were just going to happen and it wasn't going to bother the physician. In fact, one thing I'm thinking about for the next phase of this is maybe we even do a nudge. So Michael works in the nudge unit at Penn, where maybe it comes through as an electronic nudge as opposed to like a mobile heartbeat nudge to make it even easier for the physician. So this is something I have to think through more because I hate best practice. I hate those BPAs. I'm not sure if that's what it's going to look like. I would maybe not do that. But yeah, so I would just say those two things, you know, the checklist piece, because that's integrated in care. It's easy to run through. And then for those of us who are building new interventions, whether in any capacity, thinking about how to not add to the workload. So thank you.
That was wonderful. Thank you so much.
Thank you, Clark.
Lauren. I took so much away from that, and a lot of fodder too, I think, to help to inform family discussions and patients, particularly knowing that 75% of older adults prioritize their functional status over even, you know, being alive or not. And I think that's very important. I was curious about two things. One is at one point I think were contrasting or put an alternative phenotype, which is you contrasted frailty with the accumulated deficits, I think. And have people used that framework also to study patients? Are you using that framework? Is it an alternative to frailty, or
Yeah,
how
so
do you describe it?
I could talk about frailty for hours. So basically, the accumulated deficits model was the Rockwood Index, where he basically went in and took like somewhere between 70 and 90 factors out of the EMR to kind of generate like an electronic index, sort of, where the range is 0 to 1, and the closer you are to 1, the more frail you are.
Yeah.
It's really made for research. You can't really do that in real life. Ask somebody about 72 diagnoses.
I see.
But then people took that and made the clinical frailty scale from
I
that.
see. So it evolved out. The frailty scale.
Yeah.
evolved out.
However, in Wake Forest, they've now developed something called the Wake Forest, and then also Day Kim, who's at Harvard. They've done a lot of work on something called the Electronic Frailty Index, which actually takes a similar approach in that it looks for a number of different diagnoses in the EMR and spits out whether somebody is frail electronically, and it will just appear in your Epic. It's called the EFI. And so Wake Forest, and I forget, they're part of, maybe it's Atrium, they're part of this big health system now. They've actually implemented it. The problem, because I have some close colleagues there, including someone who works on this a lot, the problem is all of our epics aren't the same. So it's not like just having it in Epic in their Epic will make it appear in our Epic. But if you're thinking about, how to make this frailty assessment easier and just better so that it's easier to use in the ICU clinically, I think probably the greatest promise is with the EFI. Because it can be built into Epic and then spit out on the other end.
The other I was so impressed that you saw a finding with the pilot data with respect to delirium, but so impressed that hearing was part of that. And I'm wondering, what do you think are some of the mechanisms by which impaired hearing leads to?
There's a whole.
I know there's a whole literature on that, but
it's something that, so like I mentioned, that study we first did in 2016, that finding just has always really struck me.
Yeah.
And kind of sent me down this rabbit hole of really trying to understand. And so hearing impairment, so in the ICU, I think it's actually even easier to understand than out in the world. We already have all these alarms. We have all these medications. It's an unfamiliar environment. And now you can't hear any of it, or it's this background weird noise. You can't understand what people are saying. To me, it's pretty, I understand how that predisposes to delirium. And then I think as the person goes on and lives their life out in the world, just maybe not getting those inputs in terms of language and cognitive stimulation, there's actually strong data showing it leads to cognitive decline. But
it's delirium. It's causing delirium.
So for our study, it's causing delirium. Yeah. Sharon, anyway, yeah.
Yeah. Do you understand why though?
Yeah,
Is it cognitive? Is it?
I think it's probably not getting cognitive input, right? And you're disoriented, you can't hear what's going on around.
Yeah, one of the geriatric models of care that I didn't have. No, I know. Well, exactly. So this is one of the geriatric models of care I didn't have time to mention today is called the HELP program, which Sharon built, developed, tested, and published in the New England Journal. And it addresses hearing impairment. And so that kind of gets back to that brick wall slide. I was like, the ICU is a perfect setup for delirium. How are we not doing this already? And then we found it to be the strongest risk factor in our 2016 Blue Journal paper. And I was like, we have to deal with this. So.
You look at the freedom of your ACE trial and see what was driving the delirium increase.
We probably, and the numbers are so small, I think it might be tough to do, but I think in the larger study, this is something we'll do. And that kind of gets at, I think this needs to not be a traditional RCT. I want to make sure we're looking both at the quantitative outcomes as well as the implementation outcomes. It's actually the implementation for any complex behavioral intervention, which Doug White is going to be giving a talk on later this spring when he visits us here. And his title reminded me of this. I worry the most about delivering this to a unit and people not implementing the intervention, because you can't have an effect without implementation of the intervention. So I want to think carefully about that. And that would require looking at every component individually, even more so than we've already done.
Flora asked my question about the mechanism, but so digging a little bit, and so this is a huge effect size. It's probably it's a 2/3 reduction, risk reduction, right?
For ACE-ICU.
Yeah. So let's go on the negatives. Could be any artifacts or confounders in the population that would drive such a huge effect?
Oh, yeah. I mean, well, so first of all, this was a pre-post design, but actually that was the best design. And in talking with Michael, it needs to be stepped wedge because if you think about it, you can't randomize at the participant level because of the risk of contamination. And then your sample size for doing like cluster randomization would be huge. But all of that being said, that all those things I just said to you explain why it had to be a pre-post design and why the next one will have to be stepped wedge. But of course, there could be confounders, especially with a pre-post design, although we started enrolling the control group. Nobody knew anything was happening. Like we didn't even tell you guys. We just like went in and did the control arm. And then we started the intervention study and told everyone about it. So it's certainly possible, but I think we were also addressing 3 contributors to delirium that are not typically addressed. So it could be real. I mean, there's always equipoise for any study. I could do the next study and it could be negative. I don't know. We'll see. No. It was a pre-post intervention study in the York Street ICU because you can't randomize at the participant level because you run the risk of contamination. It's the same OTs, it's the same nurses, right?
Oh, wait, that hearing we worked.
Yeah. 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 So you can't randomize at the participant level.
Thank you is there a woman, Genta?
So it's a great presentation. Thank you very much. So in ICU, we are taking care of a lot of like oncology patient, like stage 4 pancreatic cancer patient. And it's very challenging to predict the post ICU physical activity, whether they can go back to chemotherapy after ICU discharge. Like my first question is that did those trial include oncology, like cancer patients? Or like, is there any predictive model for the kind of ICU? I mean, in specific for the like a cancer patient, like a oncology patient.
So to my knowledge, there is not a specific prediction model built for oncology ICU patients. The prediction model that we developed, again, used a nationally representative cohort of Medicare beneficiaries. So it actually does include oncology patients. And then the estimates are nationally representative. So within that group, there would be oncology ICU patients. So I would say you could still use our model. And then remember that international consensus conference, our consensus was that we needed more models because there really weren't any. So a couple more have been developed, but I have not seen any for oncology patients specifically.
I see, because I'm from Japan and I did all my training in Japan. Usually in my country, it's very, the ICU admission threshold is very high. So basically, like oncology, stage 4 pancreatic cancer, lung cancer patients, usually ICU oftentimes do not accept those patients. So I think there should be international variability of the population. Just want to
Oh, no, for
share
sure. Yeah.
my
Yeah, no, I
experience.
agree. Yes, thank you.
Thank you very much.
Thanks.
All right. Well, thank you, Lauren. And thank you, everybody, for coming.
All right. Thank you, guys. Thanks so much for coming in this hot room.